Hello, my name is Mac Light, an MD MBA student at Baylor College of Medicine and Rice Jones Graduate School of Business. Thank you for your time today in viewing our poster entitled Houston Methodist Coordinated Care ACO Goal to Improve Cardiac Rehabilitation Rates for CMS AMI Bundle Patients. The purpose of this project is to determine the percentage of patients who successfully received consults for and participated in cardiac rehabilitation, or CR, following an inpatient admission for non-ST segment elevation myocardial infarction and STEMI. On the top left, you can see we begin by addressing the question, why is cardiac rehab important in the post-MI period? CR is consistently proven to reduce cardiovascular mortality. CR may also reduce all-cause mortality and reduce readmissions. While this sounds like meaningful and positive outcomes, you may be wondering about the cost and if CR really adds value. CR is a comprehensive program that addresses risk factor management and reduces total costs. By increasing the quality of outcomes and decreasing costs, CR is a strong tool of high-value care. So, our goal is to leverage the HMCC inpatient and outpatient bundles teams to increase participation rates in phase 2 and 3, the outpatient arms of CR. On the bottom left, you can see our methods, which consisted of analyzing CMS claims data for AMI bundle patients diagnosed with NSTEMI from January to July 2021. Manual chart review was then performed to examine CR referrals, planning documentation, and CR appointment participation. Concordantly, interviews were conducted with members of the inpatient and outpatient AMI bundles team, as well as the inpatient CR team to process map the workflow for CR referrals and assessment. These data were then used to quantify the gap in patients who failed to make it to CR. Our results can be seen in the center of the poster. The identified gap in Figure 1 illustrates patients who, for whatever reason, failed to participate in Phase 1 CR, which is inpatient. Figure 2 depicts the participation rates in Phase 2 CR, conditional on having been successfully given a Phase 2 referral. The process map of the workflow for cardiac rehab referral and participation exists on the bottom. From these analyses, we're able to see that HMCC's AMI bundles patients' participation in Phase 2 CR, given a referral, is comparable to the national average around 33%. To further improve participation rates, we suggest adjusting the workflow to include referrals for Phase 2 to be placed at the same time as the Phase 1 consult. In this way, fewer patients will miss the opportunity for Phase 2 regardless of the outcome from Phase 1. We also suggest augmenting the Phase 2 referral process by including the outpatient bundles team. If while under the auspices of the inpatient bundles team, a Phase 2 referral cannot be made, then the outpatient bundles team can close that gap. We believe that this study, in accordance with the American Heart Association's goal to, quote, implement a coordinated effort to promote outpatient CR, end quote, contributes to the understanding of how patients in a large health center set in a metropolitan area are provided the resources to participate in CR. We suggest future study to be directed at identifying the specific reasons as to why a Phase 2 referral fails to translate into patient participation. Of note, we would examine the effects of patient education, beliefs, health literacy, and socioeconomic factors on CR participation rates. I would like to express my deep thanks to Dr. Julia Andrieni and Ms. Alex Gaeto for their support throughout this project. I also would like to thank the Texas chapter of the ACP for the opportunity to present this work. Thank you for your time and attention, and enjoy the rest of the abstracts.